This conference will now be recorded.
Good evening, dear colleagues, and welcome to the first live session of Online Cardiology Club with international participation. My name is Duygu, and I will be moderating the session tonight. These days, such online platforms are the best places to get the chance of interacting with influential cardiologists from all over the world. So I'm very delighted to be joined by Dr. Hatem Soliman from London, UK, and Dr. Sercan Okutucu from Ankara, Turkey tonight. As a brief introduction, Dr. Hatem is working as a cardiovascular intensivist in London, and he's mainly expertise in critical care imaging, and he has delivered numerous lectures on this topic. Dr. Sercan Okutucu has been working as a cardiologist, and he's mainly expertise on cardiovascular interventions, and he's currently working in Ankara, Turkey. Imaging has been the key part in COVID-19, actually. Even the imaging of the lungs with CT has been reported to be superior or more sensitive to swab PCR tests. So it's really critical. And tonight, Hatem will be delivering his presentation about the utility of lung ultrasound in COVID-19 patients, which is a trending topic actually in the diagnosis and follow-up of patients. Please feel free to write down your comments and questions throughout the session whenever you want using the chat tab, which you may see on the right upper hand corner of your screen. And Hatem, the stage is yours. Thank you.
Thank you very much, Duygu. Thank you, dear colleagues. Good evening from London. It's a great pleasure to be with you today on this first session on this cardiology hub. So I'm going to give a presentation on the role of ventilation and lung ultrasound in COVID-19. So the first part of the presentation will be a very brief discussion on the role of ventilation. And before starting, I want to just remind myself and remind you all that we still know nothing about this disease. We are witnessing a very new disease with very different pathophysiology and mechanism from any other disease that we have seen before. So most of the discussions that you will see on the role of ventilation are all hypothetical discussion based on expert opinions, and there's no clear evidence behind anything we do to these patients. I am relying on my discussion on ventilation on the latest theory of Luciano Gattinoni, the Italian intensivist, who proposed a theory behind the respiratory failure that happens in patients with COVID-19. So starting with this slide, we can see the quick progression of ventilator-induced lung injury in 40 hours, starting from abundant aeration on the left side with abundant areas of black color to lots of aeration on the right side of the screen. And this has only happened in less than 2 days. But it's also important to put in mind that lung injury can also happen due to self-inflicted phenomena when the patient drive of breathing becomes very high, and we will explain this very shortly. So one of the theories that explain why these patients develop respiratory failure, and especially they develop a different type of respiratory failure in which they can present to the emergency department with profound hypoxemia, with saturation in the range of 70% to 80%, but they are talking and not dyspneic. And this is quite different from anything we have seen before. And one of the theories is the development of lung vasoplegia induced by the effect of the virus, which leads to a profound ventilation perfusion mismatch in which the ventilation part remains preserved, but there will be an excessive increase in the perfusion, which leads to a state of alveolar flooding and lung vasoplegia. And this is happening because of probable loss of the hypoxic pulmonary vasoconstriction. And one of the other theories is the development of pulmonary microthrombi, as we all have heard about the very high incidence of clotting in these patients due to multiple clotting abnormalities. So this is an illustration from a study which quite explain a different disease, but it might relate to the pathophysiology of the respiratory failure in COVID-19. This is what's happening in patients with the hepatopulmonary syndrome, in which they develop a profound pulmonary vasoplegia, preserved ventilation, but the perfusion becomes abundantly deranged, and this leads to the excessive reduction of the saturation of the arterial blood due to a problem of the diffusion at the alveolar capillary level. And this is an example of how this can lead to a vicious cycle, starting with the initial lung injury, starting of the initial capillary leak, development of lung edema, impairment of gas exchange, and here we come to the idea of self-inflicted lung injury, in which when these patients start to develop hypoxia, they start to become excessively breathing and having high work of breathing, and this can lead to excessive swings in the intrathoracic pressure, which can lead to a state of excessive increase and drop in the venous return, which can consequently affect the lung in a bad way and cause further capillary leak and a vicious cycle of lung injury. So now we come to the role of ventilation, starting with the initial ways of managing these patients. If the patient comes to you talking, not really breathless, we can attempt non-invasive ventilation, which could be in the form of CPAP, for example, which can have the benefit of increasing oxygenation, and it can reduce the work of breathing. But the only problem is, if it does not help the patient to improve their work of breathing, we should not carry on with the non-invasive ventilation. Otherwise, it will cause the self-inflicted lung injury, and the patient will progressively worsen and will have probably a worse outcome. On the other hand, it can also affect the right side of the heart, may cause right ventricular failure and an element of acute lung injury. And this is a model described by Luciano Gattinoni, in which he proposed two phenotypes, two clinical phenotypes of the disease. The initial phenotype he named the phenotype L, in which the lung compliance is preserved or mildly reduced, but the oxygenation is profoundly reduced, and the lung elastance is quite high. The elastance is the opposite of compliance. And to make it, to simplify it for you, the compliance is similar to what we think of the balloon. If we have a balloon with a thin wall, it will be easy to expand. And the compliance itself is determined by two values, by the tidal volume and the pressure. So if you need high pressure to reach the target tidal volume, this means that your compliance is quite reduced. So in the type L, he proposed that the compliance is preserved, in which we typically only see the peripheral ground glass opacification in the lungs in the CT scan. But when the patient progresses to the type H, or even if the presentation starts with the type H, in which the lung compliance is profoundly reduced, and this type is similar to the classic ARDS, in which you see abundant lobar consolidation, reduction of the lung compliance, but interestingly, you will see that the oxygenation can be quite similar, despite different levels of compliance and different ventilation requirements. And this will lead us to different ventilation requirements for each type. So type L, as we described, it has high compliance, so therefore it is having lower recruitability, meaning it will not be recruitable because the compliance is not bad. So you should not attempt to give very high PEEP to these patients. Otherwise, you may cause what they describe as over-distension of the lungs, which can consequently also affect the right side of the heart. But on the other hand, the type H has very low compliance, in which you will have high recruitability. You may benefit from giving them high levels of PEEP. So what ventilation parameters we can put to these patients? Again, I am relying on this phenotypical classification, but we're not quite sure if this is the right thing or not. It is just a phenomenon, just one suggestion from experts. So the first type, the type L, can be ventilated with either volume control or pressure control ventilation, whether you will give pressure control BiPAP or volume control SIMV. And the tidal volume, the good thing in this type, in which you can give an adequate amount of tidal volume because the compliance is not reduced. So what we used to do as intensivists in patients with ARDS, in which they have very low compliance, we used to provide lung protective ventilation, in which we give them low tidal volume and high frequency. And the main idea is to avoid barotrauma, because if the lung is very stiff, the lung is consolidated, you cannot give the normal tidal volume, otherwise you would cause barotrauma and further lung injury. But this type does not have the classic ARDS features, so you can give the adequate tidal volume, which is 6 to 8 milliliter per kg, give the FiO2 as required. You can also give low levels of respiratory rate, just enough to match your minute ventilation. You can give a PEEP in the range of 8 to 10. You are not advised to give high levels of PEEP. And this is something that we have seen clinically in these patients. They don't really benefit from high levels of PEEP if they come with this preserved levels of compliance. But interestingly, despite the fact that these patients do not have reduced compliance, they can benefit from proning. Although we knew that proning is useful to help the effect of gravity by reducing the weight of the mediastinum on the lungs and further helping the recruitment of the lungs, we saw these patients improve with proning, which can be explained by redistribution of perfusion. Remember, we said that these patients have a profound lung vasoplegia and a problem in the lung perfusion. So this can be helped by the proning. And of course, they have to be sedated and paralyzed. And my main message, I think, in the ventilation topic, my only and main message to our experience, you have to be patient in these patients. Don't attempt to wake them up from the ventilator, even if they look to you in low requirement for oxygenation. And I will tell you why very shortly. The other type, the type H, as described by Gattinoni, is the classic ARDS type, in which you give them low tidal volume, high frequency, you can allow permissive hypercapnia, and the main idea is to allow hypercapnia and acidemia, is to reduce the effect of the ventilation on the plateau pressure, which helps to reduce the lung injury. So your aim in these patients to maintain plateau pressure, and of course, these patients benefit from proning, because as I said, when you flip them to the front, you help recruiting the basal areas and bit of the mediastinum against sedation paralysis. Again, you need to be patient. So to challenge Gattinoni theory, this is a paper that was released almost a week ago, which explains further 5 clinical phenotypes of COVID-19. And to make it simple for you, this paper was a bit more comprehensive, because we do know that it is not that simple to classify them into type H or type L. I would believe that every single patient has his own phenotype, and we should individualize and tailor our treatment depending on the patient. And lung ultrasound will be very useful to help us individualizing what our patient needs, as I will tell you shortly. So this paper explained 5 clinical phenotypes, depending on the degree of hypoxemia, starting with the most common type of patient, coming with mild hypoxemia, mild respiratory symptom, a normal chest X-ray. They are not hypoxic apologies. So these patients have excellent prognosis, and some of them do not even require hospital admission. And with more progression of symptom and more progression of hypoxemia and requirement for ventilation, you will have different clinical phenotypes. I would believe this phenotype is accurate, but again, I would stress on every patient has his own phenotype. So how we win these patients? COVID-19 is a long-lasting disease, which is something that we learned from our experience and our colleagues' experiences in Italy, France, Spain, and China. This disease is not like common types of respiratory failure. It takes time for the lungs to heal. So we would give them 8 to 14 days on the ventilator to give the lungs time to heal. And we use lung ultrasound in this patient to monitor the progression of aeration and see whether there are residual effects in the lungs by lung ultrasound. So our message is avoid early weaning, because one of the common problems in these patients that we use them coming down with 35% FiO2, SATs are good, they look clinically all right, and then we wake them up and then they become very breathless on the ventilator, having the respiratory swings, which are very bad to the lungs, which can progressively affect the lung in the long term. And then when you extubate them, they fail. And they can often transform from the type with preserved compliance to the type with very bad compliance. There are no studies on this, but I have seen these patients having lower chance of survival as compared to others. So once we decide that they are good for extubation, from our center experience, we extubate them straight to CPAP as much as we can. And this is an example of the hood. I'm not promoting to this company, I have no disclosures at all, but this is the type of hood we are using in these types of patients. You can use any CPAP you want, but this hood, we found it useful, and our colleagues in Italy also used it, in which you can allow the patient to see through it, and also it prevents de-recruitment after you extubate them from the ventilator. And now this is the second part of the talk, which is lung ultrasound. So I would integrate both together and remind you that I use lung ultrasound to monitor the progression of aeration in such patients and see whether they are ready for extubation or not. So let's start from the beginning. Lung ultrasound is useful monitor to assess the progression and guide weaning from the ventilator. It can help us to monitor recruitment, the response to proning, and also help weaning our patients from mechanical ventilation. And if we look at PubMed and write the words lung ultrasound in the search box, you would see an exponential increase in the number of cases of the lung ultrasound from the 70s and now. So there is a growing interest in this field, although we know that there are still limited evidence and limited data on it because it is a very evolved field. So you all know about echo, which would be very useful for lung sound very quickly and very easily. So ultrasound is not transmitted through air. We know that air is the enemy of the ultrasound beams. The normal lung parenchyma is not visible. The interface between the pleura and the lung is what reflects the ultrasound beam. And our acoustic window is the intercostal space. So we have several advantages of lung ultrasound in general, and they are actually the advantages of ultrasound, but I would add in COVID-19 the importance of safety. Ultrasound in such patients reduces the need for moving the patient out of the bed space frequently to have a CT scan. I'm not saying that the CT scan can be replaced by lung ultrasound. CT scan remains the gold standard of thoracic imaging in these patients, but I can reduce the frequency of CT scans performed if I am doing lung ultrasound to these patients. So I reduce the number of mobilizing the patients. I reduce the need for moving the patient out of the bed space. I reduce the number of healthcare professionals exposed to these patients, and I can do it immediately at the bedside as part of my integrated ultrasound examination at the point of care. I do echo, I do lung ultrasound, I do deep venous assessment, and have an integrated approach to my patient, and therefore I can reduce the cost and reduce exposure to ionizing radiation. So to perform ultrasound, what do I need? What kind of transducers I use? This is a common question because in our echo study, we use the cardiac probe, the phased array transducer. Can we use it as part of our lung ultrasound study? The answer is yes. So, but let's start from the classic way of doing it. So the universal probes required to do lung ultrasound are the linear probe, the one in the middle, the high frequency probe in which you will be able to image the pleura in high definition. And to image the parenchyma of the lung, you need a low frequency to intermediate frequency transducer, in which the universal probe we recommend is the curvilinear probe. But if you don't have this one, you can use the cardiac probe. But it will not give you exactly the same definition or same resolution and depth like this one, but of course you can use it. And I was using it for quite some time. And especially I use it if I do the lung ultrasound as part of my routine echocardiography examination in my critically ill patients. So now we know the probes, let's move to the zones of the lungs in which we are scanning the patients. There are several protocols. None of them are proved to be better than the rest, but this is what we use in our center, and many of my colleagues are using as well, is the 6 zones model or 12 zones model. 6 zones on the right, 6 zones on the left. We can also use the 8 zones on the right and 8 zones on the left, and I'll explain to you very quickly the difference. So the main idea is to divide the lungs virtually or by imaginary lines into anterior, lateral, and posterior zones. You can have two long posterior zones. So you have zone 1, 2, 3, 4, 5, and 6, and 7, and 8. Be 5 and patient. This may be a challenge. They are often supine, might be challenging because fine and difficult to move. So I would zone, and these lines are the external line, anterior axillary line, the posterior axillary line, and the paraspinal line. And my horizontal line is just below the nipple line. Then I have the 6 zones. I would argue that the most important zones are the posterior zones, because this is where the devil usually hides, and this is where the nasty consolidations and atelectasis are often present in the critically ill patients who are lying in bed. So now we come to where I put the probe on the patient. So depends on what I'm thorax, ultrasound on the thorax, but this is not covered fully in this webinar. So when we use the linear probe and we put the probe vertically in the second intercostal space, mid-clavicular line, the indicator to the patient head, as you see in the above image, and this will give you the initial image that I will show you very quickly in the next few slides. Why I'm putting the probe in the upper zones? Because air goes up. When I'm scanning, the air goes up. Interstitial fluid, on the other hand, I put my curvilinear probe at the dependent zones when I'm looking for heart failure, for example. So I put the probe in all systematic zones, and when I'm looking for pleural effusion, I put the probe at the costophrenic angle with the indicator to the patient's head and mid-axillary line, as you can see in this picture here. And with this position, you would expect to see the diaphragm as the mark and the liver below on the right side, spleen below the diaphragm, and then the diaphragm on the right side, and I fold. All right, so what's normal? So when I put the linear probe, remember I showed you the linear probe in the second intercostal space, mid-clavicular line with the indicator to the patient's head. This is the first thing that I will see. The first thing is having the 2 shadows at both sides, this black shadow, and I see the shimmering pleural line in between. So this is the shimmering motion of the lung sliding, in which you see the shimmering of the sliding of both the visceral and parietal pleura. You don't see both layers separately in this, but you clearly see the shimmering motion of this sliding. And when you look with this in this image, you see there are mirror-shaped artifacts or horizontal reflections of the pleural line at equal distance. These are called A-lines, which reflect aeration. They are often happening in normal aeration, but they can happen in abnormal aeration in the setting of pneumothorax. Just keep this in mind. But A-lines often means normal aeration. And this is described as the BAT sign, as described by Daniel Lichtenstein. So the BAT is important to get so you can avoid mistaking the pleural line with any other lines of the chest wall if you don't put your probe vertically initially. So imagine if you start your probe horizontally without seeing the rib shadows, you might not clearly identify this as the pleural line. That's why we start vertical and then rotate the probe. Counterclockwise or clockwise, I don't think it matters. And this is what you see when you rotate your probe. You will see the shimmering pleural line. Again, this is again vertical. This is horizontal position, because here you see rib shadows, here you do not see rib shadows, and you see the shimmering motion of the pleura. And when I confirm the lung sliding, I put my M mode cursor and I look at this classic pattern of seashore sign as described by Denny Lichtenstein. So what is the seashore sign? It's a confirmation of the sliding in which you see the waves on a sandy beach as described. The waves are reflecting the chest wall. The breakers are reflecting the very white and bright pleural line, and the sand reflects the lung parenchyma. And the most important part of this pattern is the sand, because once you have air between the visceral and parietal layers of the pleura, you lose the ability to see beyond, and you don't see the sand. You will see then a reflection of the chest wall, and you will see mirror-shaped artifacts and barcode, as you will see shortly. So this is a confirmation of sliding. Why lung sliding is important? Because lung sliding rules out pneumothorax. Explicitly said, it rules out the presence of pneumothorax at this point of scanning. So again, these are the A lines, horizontal reverberations of the pleural line. Notice that we are using the cardiac probe here. You have these horizontal mirror-shaped artifacts of the pleural line. For some reason, the video is not moving. I don't know why, but usually you see the reverberations of the pleural line. So what happens if we have absence of lung sliding? We have several causes for the loss of lung sliding. We have pneumothorax. We have right main stem intubation. If you have intubation of the right side, you will lose sliding on the left side of the lungs because there is no tidal volume. In the setting of massive atelectasis, in the setting of pleural fibrosis adhesions, in the setting of cardiorespiratory arrest. So anything that causes extensive disease of the pleura, so it loses the ability to slide, and also anything that loses the tidal volume to let you not able to appreciate the presence of sliding. And again, I don't know why this video is not playing. There's probably a technical issue here, maybe from my side. Do you hear me, guys? Hello?
Yes, I do.
Yeah.
Yes, we do hear you. I just unmuted myself. There's no problem.
I didn't lose you. All right.
Yes,
So
we close our webcams.
Great. Okay.
Yes.
So can I suggest just to close and reopen my presentation, because I am afraid that the rest of the videos might have an issue, just to make sure they are working. I'll just close my PowerPoint and open it again. Is that
sure?
Just a few.
Yeah, that's okay.
Thank you. Just to make sure, because these videos are quite very important. Right, so we are here. Oh, let's hope it works. That's it. So these are the lines, right? And the horizontal. Remember, this is the pattern that when we see this pattern, we say there is aeration. All right, this is very important. In our COVID-19 patients, we will have different grades of aeration and loss of aeration, as we will discuss very shortly. So this is the initial pattern of normal aeration. And this is an example of the loss of sliding. I told you the examples, so this is important to put in mind that pneumothorax is not the only cause of loss of lung sliding. And if you look here at the screen, you will see that there's no sliding all through the pleura, but the last bit of the pleura show a bit of shimmering. Can you see that? So this is a point of the transition zone between the sliding and no sliding. And this is described as lung point, in which you can identify the point of the presence of the pneumothorax and separate it from the rest of the lungs, which is very specific for pneumothorax, by the way. So I just told you about the barcode, and this is the barcode. Look how impressive when you see it. But remember, the loss of sliding is not only caused by pneumothorax. You should have other signs as well to confirm or give you high chance of diagnosing pneumothorax. So moving forward, the second sonographic sign is very important for us as intensivists, as cardiologists, because it is the sign of the alveolar interstitial syndrome. It is described as the B lines. It is different from the Curly's B lines, although they can both happen in heart failure. You know, the Curly's B lines, they sign in X-ray, but this is a sonographic vertical like comet tails, as you see here. So when you look into the lungs, you don't see lines anymore, right? Because the B lines started to appear. They are vertical like comet tails. They reflect an increase in the extravascular lung water. And the extravascular lung water is responsible for the development of pulmonary edema, whether it is cardiogenic or non-cardiogenic pulmonary edema. And it starts initially interstitial, and when it progresses, it becomes alveolar in high degrees of pulmonary edema. And how to diagnose or how to make sure that these are B lines, you have certain criteria. So they should start from the pleural line. They should go until the end of the far field. They slide with the pleural sliding, and they hide and obscure the A lines underneath, but you can find them together sometimes if the B lines are not abundant enough to obscure the B lines. And very importantly, the fact that these B lines have to extend to the far field, because if you have B lines which are very short and not moving with the sliding, they are not B lines, they are not pathological B lines, okay? And the other question is, when do I consider B lines to be pathological? Is the presence of B lines on its own is enough to consider it pathological? No, the answer is no, because you can have up to 2 B lines in one intercostal space as a normal finding in normal healthy individuals. But if you start to see 3 or more B lines, especially these are plenty, you cannot even count them, you would consider this to be an abnormal sign. And why this is important in COVID-19? Because this reflects a moderate degree of loss of aeration. Remember, I told you the A lines are the best aeration. The intermediate degree of loss of aeration is the presence of B lines. And it's very, very common in COVID-19 respiratory failure to present with confluent, abundant B lines. They have certain criteria, as I will discuss in the next slides. So these are different examples of B lines. When you have B lines in heart failure, the B lines are often well spaced together, and they are often symmetrical on both sides of the lungs, because thinking of the pathophysiology and the progression of heart failure, it happens bilaterally unless you have not common causes of heart failure causing unilateral pulmonary edema in the setting of eccentric severe mitral regurg, for example, but this is not common. We all know that the very common heart failure happens if cardiogenic pulmonary edema, it will be bilateral. And then you will see bilateral symmetrical B lines on both sides of the lungs. And I want you to look at this nice video here. You will still see the A lines underneath. Do you see that? So despite the fact that you have plenty of B lines, but they are not enough to obscure the A lines completely. All right. And when you look at the B lines, it's also good to look at semi-quantifying the extent of the B lines. Are they many, but they are not confluent? So they are not combined together to make curtain-like pattern like this one. So if you look at the middle here, you can see isolated B lines, but on the left side, you see a small curtain here. So this curtain is not a single B line. This curtain is composed of multiple B lines combined together in a confluent manner. So this often represents an increased degree of alveolar edema. And this is an advanced degree of alveolar edema. If you have a patient with cardiogenic pulmonary edema and coming to you hypoxic in the cardiac intensive care unit, and you scan the lungs, you very commonly see this pattern, confluent-like pattern. So the pattern of the lung changed from black to white. You see white instead of black. And this is, again, in heart failure, it will happen bilaterally and symmetrically. And in COVID-19, it will be different, as I will tell you shortly. So what are the importance of B lines in heart failure? So ironically, despite the fact that the analysis of the lung ultrasound artifacts was started and pioneered by anesthetists and intensivists in France, the integration of B lines was more actively done by cardiologists. And we now know that B lines are part of the heart failure guidelines. It is proven to be useful in diagnosis, monitoring therapy titration, and risk stratification and prognosis. And it can be useful to monitor dialysis patients and also patients with ARDS. And that's why we're talking about COVID-19. So this is a very important thing to put in your mind. The different grades, the different shades of gray in terms of the COVID-19 and in terms of the adult respiratory distress syndrome. Starting from the black, the best aeration, in which you will have A lines, then you will start to see two patterns of B lines, whether it is plenty of B line, but they are not confluent. So they are giving you this black and white pattern. And when the B lines are curtain-like all over the screen, making the screen look bright and white, this is a pattern of alveolar edema. And the worst degree of aeration will happen when the fluid is replaced by tissue. So imagine the alveoli, which is normally filled by air. If the air is replaced by fluid, this is a moderate loss of aeration, and you will see it as B lines. If this fluid is replaced, I'm talking about alveolar interstitial edema specifically. If this is replaced by tissue consolidation, this is the advanced degree of loss of aeration, which is happening in classic ARDS. And these are different examples of different types of progression of the B lines. Normal A line pattern, no B lines, one B line, two B lines. Remember, these three are normal because you have up to two B lines in one intercostal space. But once you start to see three B lines or more, this is abnormal. And how to differentiate ARDS and cardiogenic pulmonary edema. I already give you a hint. In cardiogenic pulmonary edema, you will see bilateral symmetrical B lines more at the dorsal spaces by gravity. But in ARDS, you will see patchy confluent B lines, which is very classic for patients with COVID-19 and ARDS in general. So you see patchy and confluent B lines. What does it mean to be patchy? It means when you put your probe, you might see areas of curtain B lines in between areas of normal aeration, areas of A lines. Because if you imagine it, and if you look at the CT scans, you see the patchy distribution of the ground glass opacification. And also good to mention that the B lines on lung ultrasound, the curtain-like B lines, are well correlated with the ground glass opacification on CT. So you can imagine how much useful it is to perform lung ultrasound in these patients. The other important thing to differentiate between ARDS and cardiogenic pulmonary edema is to look with the linear probe, the high frequency probe, at the pleura, and looking at the pleural health. So the normal pleura is thin and healthy, and of course we talked about sliding, but the irregular and unhealthy pleura is usually showing like that. It will be thick, it will be irregular, you will have subpleural hypodensities like this. The pleural line will be shaggy and not as thin and healthy like this one. So this is the pleural line of patients with hydrostatic edema and heart failure, and this is the pleural line in a patient with ARDS and non-cardiogenic pulmonary edema. And these subpleural consolidation are seen very frequently in patients with COVID-19 pneumonia, but they can happen in any pneumonia and ARDS. But remember, you can have overlap between these two. It is not surprising to see patients with ARDS and heart failure. And then it will be very important to utilize and integrate all your findings with your clinical context. So again, on the right, curtain-like B lines, heart failure patient. On the left, this is from a real patient with COVID-19. You see the subpleural consolidation, very big hypodensity under the pleural line. Remember, this is done with a low frequency probe, but this is done with a linear probe to look at the pleura. And again, in ARDS, you will see consolidation at the basis in classic ARDS, but in heart failure, in pure hydrostatic edema, you will see pleural effusion more commonly on the right side. And these are different examples of pleural effusion. I'm sure you all know the pleural effusion. You see it while you do echo study, black fluid, and this is a compressed lung. It can be described as compression atelectasis, where you have large pleural effusion and the lung is collapsed and floating inside the bag of fluid. This is described as the jellyfish sign. And remember when I told you that we put the curvilinear probe at the mid-axillary line with the indicator at the patient's head? Your landmark will be the diaphragm here, and below the diaphragm will be the liver on the right side and the spleen on the left. And looking above the diaphragm, you will try to search for abnormalities. And here you will see pleural effusion black, and this is a collapsed lung. And these are real-life cases from patients with COVID-19 in which you see different grades of subpleural consolidation, different intercostal spaces. It's quite big and sizable. And I saw it clinically. I could, from my experience, that I've seen this goes away and become less bigger with time when the lung starts to heal. So this often seen at the patient on the initial presentation with very severe hypoxemia and the initial hit of the lungs. So on the right lower side here, you don't see that bad subpleural consolidation. So it's very important to scan the different zones of the lungs. And again, these are from real patients with COVID-19, and you see this very striking patchy white curtain-like B lines. You don't even see the individual B lines, but you see them combined together, confluent in the pattern of curtain. And in between them, you see A lines here. Do you see the pleural and horizontal A lines, mirror-shaped artifacts? So these are A lines, normal aeration, and adjacent to that, you see area of patchy B lines. This is typical of patients with COVID-19. And the other thing you could see the curtain B lines coming out of the pleural line, where you see the irregular pleural line here with curtain B lines coming out, or they can come out of a thin and healthy pleural line. And one of the signs recently described by Giovanni Volpicelli is the light beam. So it is noticed that in early stage of the disease, you can see this on and off, the presence of the patchy white curtain-like B lines coming from a thin pleural line. Some people propose this as a sign of early active disease. And here comes the scoring of the findings that we saw. So remember, we put together 4 levels of aeration. So what if we put this together as a score, as described by Belaid Bouhamad several years ago, in which he put a different lung aeration score by ultrasound. So he gave score of 0, which is the best aeration for A lines, score of 1 to non-confluent B lines, score of 2 to confluent curtain-like B lines, and score of 3 to the worst aeration, which is the consolidation. So if you assign a score to each zone of the lungs, you will be able to get a lung ultrasound aeration score for the right lung and the left lung. And remember to put together the number of areas of subpleural alterations in every study you do, and also commenting on the pleural effusion. The scoring on its own is not entirely validated in these patients, but it can be useful to monitor the progression of aeration and the response to recruitment. And I would also suggest that we can use the scoring to assess their readiness for extubation as part of an extubation protocol, along with the other clinical and imaging parameters. So this is from the same patient that I show you the big subpleural consolidation. 2 weeks later, we saw the health of the pleural line. The pleura is thin. You don't see subpleural consolidation anymore. And if you scan the lungs, the parenchyma with the curvilinear probe, you can see the difference very obviously. Do you see the patchy curtain-like anymore? You don't see it. So this is an example of the progression of aeration. And this is quite assuring for you if you want to wake the patient up and extubate the patient. You can notice the presence of B lines, residual B lines, quite few as compared to the initial one. This is not uncommon because as I said, this is a very slowly healing process, and some patients unfortunately develop a sort of long-term affection of the lungs, which might heal with time, and I'm afraid some of them might not, but we still don't know yet. So here, to summarize the clinical benefit of lung ultrasound, it can be an extension of your clinical examination, as I always recommend ultrasound to be part of your clinical decision-making and part of your clinical ward round, assessing recruitment, and can help you to guide your extubation to these patients. It can also be used to assess these patients, triaging patients to different management pathways, depending on their level of oxygenation and the lung ultrasound findings. So then you will decide whether they can be managed at home, they can be sent home, they can be admitted to the hospital, they can be admitted to the intensive care unit. You can risk stratify, prognosticate, and as I said, of course, we can use it to monitor the disease progression. And this is a protocol lately developed by the Intensive Care Society here in the UK, in which they put the lung ultrasound findings in a data set to try to give you a management protocol for these patients. The most important thing is to try to use it as a monitoring tool to assess for the progression or resolution of the lung problems. And I always call for an integrated approach. So we use the echo, lung ultrasound, pleural ultrasound, scan the neck veins and the deep veins, look at the IVC, you will have a better picture of the patient. But remember, this should not replace your clinical context. You have to put this in the clinical context of your patients. And these are different examples of the integrated approach. Patient with hypovolemia had hyperdynamic left ventricle, flat IVC and A lines. Then you would give them fluid, especially if you see small right ventricle. And this is another patient with dilated RV, plethoric IVC, and lung point, the one I told you earlier on. I did not cover pneumothorax on this topic just for the sake of time in this webinar, but you can see it online in my other webinars. So tension pneumothorax, lung point, plethoric IVC, and dilated right side. If you see dilated hypokinetic ventricle with plethoric IVC and abundant B lines, you would diagnose hydrostatic edema and heart failure. And if you see strain of the right ventricle, dilated right side of the heart, plethoric IVC, abundant A lines, and a clot in one of the deep veins, you would suspect pulmonary embolism. I would not finish without stressing on the importance of limitations. And I would think the main power of lung ultrasound lies in the hands of the operator who knows his limitations. So again, this is a very evolving tool. We should not lose it. How we are going to lose it? If we do it wrongly, and if we do it with overconfidence. We should know our limitations and always put our data cautiously in the clinical context. Remember, you might miss pathologies deep within the lungs because lung ultrasound is very good until certain limit in the depth of the lungs. It is affected by training and experience, and some colleagues in their studies recommended 25 supervised lung ultrasound studies to make you able to perform lung ultrasound independently, which is not as much as compared to echocardiography. It's very easy to learn. Again, I'm encouraging you, I'm repeating the message, it is easy to learn. And remember the potential of human transmission of COVID-19. So I would finish by a take-home message. Please remember to be patient with your COVID-19 patients who are ventilated. Don't be tempted to wake them up and extubate them early on if you see their oxygenation is good. I would use lung ultrasound to guide me in assessing the readiness for weaning and extubation from the ventilator if it's available. We still know nothing about this disease. It's a very new disease with very limited evidence and very dynamic information. So we are learning on the go. And I would stress on the facts, and I hope you agree with me now, that lung ultrasound can be very useful in these patients and also in other patients in our cardiology practice and intensive care practice. And don't forget the integrated approach. Always do all the tools you have to try to get the best information to help your patients. Thank you.
Well, thank you, Hatem. That was a fantastic presentation. I hope everyone enjoyed it. We have plenty of questions, so I will start asking them to you. First, they're asking how often you perform lung ultrasound in your clinical practice for COVID-19 patients.
So it's a question for me. So how often I do it, it doesn't apply to anyone else because there are no clear rules on how often you should perform lung ultrasound yet. But I try to do it once daily, especially in those in whom I want to assess the progression of aeration. So remember the score. I try to do it once daily and assess the scoring and document it. And put in mind that you might need to do more than once in the setting of defibrillation. But I would think of once daily. Twice daily might be a bit difficult. So, but again, still, my experience is once daily, but it doesn't apply to anyone else.
Sure. And another question is there a specific sign on lung ultrasound that highly suggests of COVID-19? You mentioned about the patchy and confluent B lines. Is there a specific sign that discriminates it from the causes of other non-cardiogenic shock, ARDS? Can you?
Unfortunately, there is no specific sign. Remember, I talked about the recent sign suggested by my colleague Giovanni Volpicelli, which is a light beam. So it could be found in patients with early stage of the disease, in which you have on and off patchy confluent B lines coming out of a thin pleural. But again, I cannot say that there's any sign that's happening in COVID-19 which does not happen with patients with ARDS.
So that early sign that you mentioned, maybe the severity of lung ultrasound in a patient suspected with COVID-19 in the emergency room compared to CT scan, maybe could be an early sign of the disease, right?
Could be, yes. So this was the finding of Giovanni. So he suggested that this could be a sign of early COVID-19 because it was found commonly in these patients, especially when they present to the emergency department with the initial presentation. So this is true, can be an early sign.
Yep. Some of our participants ask about the use of any transducer in order to perform lung ultrasound, and you mentioned it in the beginning of your presentation. But can you again repeat about it? Sure. The utility of cardiac probes?
Sure. So as we said, the universal probes are the curvilinear probe, in which we use it to scan the parenchyma of the lung, and the linear probe, in which we use it to scan the pleura. So I differentiate between pleural and parenchymal ultrasound. Both make the lung ultrasound. But if I don't have the curvilinear probe, I can still use the phased array cardiac probe. It might not be as good as the curvilinear, but it is good. It can give you the information you need. You will see B lines. You may not be able to see the pleural line, because remember, when I showed you images of COVID-19 with the patchy white confluent B lines, this was a curvilinear probe, and you could see really clearly the pleural line. With the phased array transducer, you might not have the ability to see the pleural line as good as the curvilinear probe, but it can be good to show you the presence of B line, the extent of B lines. Of course, you will see effusion, you will see consolidation. So I would encourage you to use it if you don't have the curvilinear probe.
So, sorry, sure, go on.
Especially if you will use it as part of your echo study.
Yep. So you mentioned about seeing the confluent B lines in COVID-19 patients. Is it possible for us to see those confluent B lines in cardiogenic pulmonary edema as well, or is it an uncommon finding?
No, in cardiogenic pulmonary edema, you will commonly see confluent B lines, but they will not be patchy. They will be symmetric, bilaterally, and diffuse everywhere. Unless you have like a couple of years ago, maybe, for example, I have a patient in which I did a lung ultrasound. He was hypoxic, he was distressed. He had a recent cardiac surgery. And when I scanned the lungs, I saw on the right side extensive B lines. There are no areas of A lines at all. On the left side, A lines everywhere. So when I did echo, I saw eccentric severe mitral regurgitation. So this patient had a unilateral pulmonary edema, hydrostatic.
Yeah, that's an extinction, yeah.
But this is not common. The common is to see the cardiogenic pulmonary edema bilaterally and not patchy.
Yeah. Okay, let's proceed with other questions. There are too many comments coming for you. So one other question from Dr. Altensoy, she asks, does curtain sign exclude pneumothorax?
Oh, yes, of course. Thank you, Milka, for this question. So the presence of B lines rule out pneumothorax. I did not cover pneumothorax in this webinar, but B lines, one of the things that is lost if you start to see pneumothorax. So to diagnose pneumothorax, you will lose B lines, so then you will not see curtain, because you will not be able to, the ultrasound beam will not reach the parenchyma of the lungs. So you will not see B lines, you will not see curtain. Then the answer is yes.
Okay, one other question, the hypercoagulability in COVID-19 patients, and we may encounter pulmonary embolism in these patients, So Dr. Sinan asks if there is any specific signs associated with pulmonary embolism in these patients that we can detect on lung ultrasound.
I don't know. I haven't seen specific sign for, and I'm not aware of any lung ultrasound sign for pulmonary embolism in these patients. No.
One interesting question asks about the timing of the acquisition of the images during lung ultrasound. Does the patient has to hold his breath or expire?
No, I mean, we often do it in patients on the ventilator. I mean, I work in an intensive unit, and the majority of my patients are intubated and ventilated. So I don't ask the patient, or I don't do a breath hold, for example, on the ventilator. I just do it, regardless of the breathing, regardless of the respiratory phase.
If the patient presents to emergency department, should we still not ask for a specific breathing position or not?
I
Provided
don't think
that
so.
the patient can breathe normally. Okay.
I think the
okay,
patient
one
can
other
breathe.
question. Oh, sorry.
That's okay.
The other question is about the position of the patients for the optimal lung ultrasound. You mentioned about it actually. Because some patients are lying in the prone position. Most of them are intubated. So yeah, position would definitely be affecting your procedure. But can you again repeat about the importance of the patient position?
Sure. I mean, if we have the option of sitting the patient up, I mean, not all patients are ventilated. I mean, we have patients who are intubated. We have patients who are on non-invasive ventilation early on. So we can, ideally, we should do it comprehensively while the patient, if he can sit up, so we can scan the posterior parts of the lungs. And remember when I talked about the 16 zones model instead of the 12 zones. So if I can do 8 zones on the right and 8 on the left, so I can comprehensively do 4 posterior zones instead of 2, that would be ideal. But only if the patient can sit up, or I can reach clearly the posterior parts of the lungs. But if we can't, if the patient is supine, I can try to roll the patient slightly to one side to try to reach as posterior as possible. I mean, as I said, this is where the hidden consolidation can be found. So maybe slight rolling, but making sure the patient is safe in the bed.
One other question is about the use of lung ultrasound in acute decompensated heart failure patients. In order to count the multiple B lines in these patients, are you using the scoring system that you showed us? Or do you only count the number of B lines, like 2, 3, etc.? So is it the same system in acoustic compensated heart failure patients as well?
I don't think this scoring was developed for heart failure patients at all. This scoring was developed exclusively for patients who are with ARDS and ventilated. So I'm not aware of scoring available for patients with cardiogenic pulmonary edema. And from my own experience, I don't count the B lines because I work I work in an intensive care. So I don't do ambulatory heart failure patient monitoring and assessing the progression of the number of B lines. This can be useful for some of you who are doing outpatient clinics, but I rely on the semi-quantitative way and the pattern of aeration in terms of confluent B lines or non-confluent without applying the scoring in heart failure patients.
Mm-hmm.
And
And
scoring, the part of the scoring is the consolidation, which is not part of the heart failure process.
Really? Mm-hmm. I have a question, like how long does it take to be trained in lung ultrasound? How many cases should you perform before considering yourself qualified on it? Is there a minimum number of cases to be read?
That's a very good question. Thank you for that.
Mm-hmm.
So as I said, there are studies which showed that probably around 25 of supervised scans can be enough to lead you to become an independent lung ultrasound practitioner. So I think about 20 to 25 scans can be roughly the number that we can suggest for someone, but these are all supervised scans with different pathologies and different parts of the whole spectrum of lung ultrasound findings.
Do you know, is it a part of clinical training in cardiology in your country?
The lung ultrasound?
The lung ultrasound training? Yeah, the lung. Do you do the cardiology trainees receive lung ultrasound training like we do for echocardiography, for example?
Do you know, I'm not sure. I might ask them. I hope that. I hope that it is the. But I think it is starting to become more and more popular now. I hope that's part of the training, and if not, I'm sure it will be in the near future.
Yeah, it seems so. Yeah, it's a really hot topic these days, and I also believe that it will be implemented in the clinical training in Turkey too, maybe in the future years. So Hatem, thank you very much. It was an excellent presentation, and you gave us too many examples so that we could easily understand the complex B lines. That was really useful. So I'd like to proceed to our second presentation right now, which will be given by Dr. Okutucu. You know, Cath lab is a place where cardiologists spend most of their time and they see too many patients. So there's a rapid patient turnover there. This week, several societies have started releasing their guidelines on how to reintroduce the cardiovascular procedures and diagnostic tests. And now Dr. Okutucu will be giving clues to us about what changes we should be implementing in our routine clinical practice in this pandemic. Yep, Dr. Okutucu, the stage is yours.
Thanks a lot, Duygu, and thanks to Dr. Hatem for the fantastic presentation. In the following 15 minutes, we will briefly overview the consideration for Cath lab during the COVID-19 pandemic. And here is our agenda. We will start with the COVID-19 and cardiovascular concern. Then we will briefly overview the risk categories and asymptomatic carrier concept. Then we will summarize the COVID-19 related protection level, which are namely level 1, level 2, and level 3 protection. Then we will briefly go over pre-procedural, procedural, and post-procedural some main points. And then we will finish with the management of specific situations. And as we all know, the COVID-19 has many cardiovascular concerns, and the patient with pre-existing cardiovascular disease has the higher mortality risk. And in this disease process, there are many cardiovascular manifestations, including the acute coronary syndrome plaque rupture, myocarditis, the heart failure and arrhythmias, and the side effects of the COVID-19 therapies are also present. And this might bring the patient to our cath lab. And in our cath lab, the COVID-19 is actually is an occupational hazard for us and for our patients. So as like all occupational hazards, we should check the reverse pyramid, which is shown on the left side. So the most important step is to eliminate this danger. So we are doing in all our life the social isolation. We can substitute this with the vaccine, hopefully. Also, there might be some engineering controls like ventilation and physical barriers, some administrative control like work from home, changing the schedules, and hygiene and dedicated cath lab. And although it might come strange, the personal protection equipment is the least effective, but of course it's also important. And here on the right side, we can see that this virus can stay as aerosol in the air up to 3 hours, and it can live and stable on plastic and stainless steel up to 3 days. And in this table, we will just look to a few points. This is from the ESC guidance, which is recently published. And as we know, there is a concept of confirmed case. Confirmed case, a person with the laboratory confirmation of the COVID infection. And there is probable case. In the probable case, either the testing is inconclusive or the test couldn't be performed for any reason. And as it initially defined, the suspected case is the patient have the symptom and also the travel history or prior contact with a patient with a disease, or having the severe ARDS and unexplained etiology for this. And negative case, the patient have the 2 negative COVID tests, or patient recovered from infection and have the 2 negative tests with 48 hours apart. So after this, also we should look to another concept. This ship might seem like love ship, but it is actually the Diamond Princess. Diamond Princess give us information about the asymptomatic carrier and the pre-symptomatic transmission. In Diamond Princess cruise ship, about 20% of passengers were asymptomatic carriers. And according to initial data from Asia, the pre-symptomatic transmission is around 50%. So it means we are really have danger to expose this virus even with the patient that we didn't suspect to have the COVID. So the protection is very important. Here on this slide, we can see the COVID-19 related protection levels. This is from ESC guidance. There is a level 1 protection. In the level 1 protection, we have the disposable surgical cap, surgical mask. We have working uniform and latex gloves. This is what we are doing in our outpatient clinic, and also for the patient that we don't suspect any infection or there is no confirmed infection. In the case of the level 2 protection, here on the right side, we can see for the all suspected or confirmed case, patient should have the disposable surgical mask, and we should have the surgical cap, the medical protection mask, respirators, and the working uniform, gown, disposable surgical gloves, and goggles. And also we should use this level of protection if we are doing the percutaneous invasive procedure or TE, or for the staff that are doing the cleaning of the TE or stethoscopes or other stuff. And the level 3 protection is actually in many of the paper, it's written, okay, this is for the anesthesiologist, but actually this is not for anesthesiologists, also it's for us too, because our patient can have the cardiac arrest, we might need to do CPR, or we might need to intubate the patient, so we should use the level 3 protection in these patients. And for all protection, the donning and doffing is really important. We should do this in a proper way and in a proper order, the donning and doffing subsequently. And let's look to some important points for a COVID-19 positive patient for pre-arrival. Of course, the area that receiving patients should be notified before, and we should avoid the COVID-19 patient to stay in the waiting areas, and the anesthesiologist should be pre-alerted in case of intubation. It's better to have dedicated cath lab for COVID-19 patients, and only the staff involved should stay in that room. and the patient should have the surgical mask before entry to the lab. And what we should do peri-procedurally, of course, we should keep the door closed and avoid entry and exit of the staff for any reason for bringing material. So it's better to have dedicated COVID-19 cabinet with our workers' guide wires, some of the stent sizes, and also it's important to minimize contact with the surfaces. And we should keep the procedure as simple as possible. Sometimes the culprit vessel intervention and the waste disposal and cleaning should be done accordingly. And for the post-procedural requirement, of course, if patient have a confirmed COVID-19 infection, the operator should be notified, and the record of the all staff should be done, and the staff who gave care to confirmed COVID-19 patients should be vigilant for the symptoms in the next 14 days. And let's look to some specific situation. So the STEMI in the COVID pandemic is a little bit different because there are extra delays according to initial experience that are reported from China, and this patient has delay around 5 hours or 6 hours. Because people worry to admit to emergency department, they usually admit late, and we have more mechanical complication during the course of the myocardial infarction. And although it's a little bit controversial, the fibrinolysis might be selected in might be performed in selected cases. And of course, this patient we have in this patient we don't have enough time so to wait the results. So we should accept this patient like having the infection, and we should treat them accordingly. Here on the right side, we can see the Esc algorithm for the management of STEMI, and they summarize that if the patient have the high-risk condition like anterior myocardial infarction, hypotension, high Killip class, cardiogenic shock, and life-threatening arrhythmia, so it's better to progress on the with PCI. But if patient doesn't have the high-risk features, so we can think about the fibrinolysis, and if the patient needs the rescue, then we can do rescue. In this slide, we can see the recently published Esc algorithm. In that slide, I want to point out that the Esc algorithm supports the PCI, but if there is high, I mean, it's more than 60-minute extra delay for the PCI, so it's better to introduce the fibrinolysis in that situation. And in the case of the non-ST myocardial infarction, the patients with the very high-risk feature should follow the same pathway like the STEMI, and the healthcare provider should protect themselves accordingly, and others should have the nasopharyngeal swab, and according to result, we can progress for their treatment. And if we think about the specific subset, which patient we should consider deferral for intervention, of course, the first group should be the elective cardiac structural or vascular procedures. And it might be a little controversial, but STEMI patient with severe ARDS can have the conservative treatment or fibrinolysis. And non-ST elevated myocardial infarction with low-risk features might be deferred for the non-invasive testing. Of course, type 2 myocardial infarction, either secondary to the ARDS or sepsis, should be deferred, and also the troponin positive myocarditis. And during this specific situation, patient can have the cardiac arrest, of course. In this slide, we can see the recently published paper by AHA about the advanced cardiac life support, and the important points are highlighted. And the most important point is first protection, that we should protect ourselves, we should don our personal protective equipment, and we should limit the personnel, and we should consider the resuscitation as appropriate or not. And the main important keyword in this document is to limit aerosolization and to do best intubation practice with minimal aerosolization. And during the intubation, we should stop the chest compression. We should wait for the intubation, And if intubation delay, we can consider the supraglottic airway or bag mask device. And we can continue with the ventilator with special pressure control settings during the CPR. And the rest of the algorithm is pretty much similar with the previous one. So the key messages are our readiness is really critical to provide the safe and best quality of care in cath lab. So and also rescheduling of non-urgent and elective procedure is important, and we should carefully select the patient for urgent and emergent procedure. We're thinking about the risk and benefit, and we should do meticulous donning and doffing of the personal protective equipment with the cleaning of cath lab. Thank you for your attention.
Well, thank you, Dr. Okutucu. It was an excellent presentation. Actually, I have a question to ask you. Have you, I don't know if you have experienced any COVID positive STEMI patient, but have you ever read or seen on the literature about the changes in dosing for antiaggregants or anticoagulants in a patient undergoing PCI for STEMI?
Yeah. Yes, theoretically yes. I didn't read this specifically, but this patient can have the many antiviral agents and the COVID-19 specific treatments. So we should think about our antiplatelet regimens and the cytochrome interactions, like what we do in HIV positive patients. And also the statins. Statins are also important. We should be careful for introducing the statins and also the antiaggregants. We personally use the non-clopidogrel antiaggregants like the ticagrelor or prasugrel sometimes.
And we have a question asking about the diagnosis of COVID-19 prior to an intervention in an acute coronary syndrome patient.
Yes.
So do you routinely?
Yeah, we routinely do it, and we have this web, but of course we progress to cath lab in STEMI patient, and as like I summarized during the presentation, we are doing exactly the same protocol.
So have you observed a decrease in the trend of patients being admitted to the emergency room due to unstable angina in this period, in the pandemic period?
Yes, yes. Especially, yeah, actually, we are now started to do our outpatient clinic. Now that they apply in our outpatient setting. But for STEMI, they usually apply late, and sometimes they don't apply. And we had more, I mean, the patient with the mitral regurgitation, with severe mitral regurgitation, or the low VF because of the late admission. So,
as far as I understand, you haven't adopted the fibrinolytic therapy in this era, right? You accepted the patients to the cath lab, providing the optimal precautions.
Yeah,
right?
Yeah. If you need to take the STEMI patient, so you should accept it like having the COVID-19 positive patient. So you should protect yourself and you should do the same protocol because the results will be, you will get the results later.
And most cath labs in Turkey don't have the negative ventilation systems, therefore not designed for infection control. And did you make any timing changes in the intervention plans of the patients? I mean, doing their interventions in the latest, as the latest case of the day, maybe.
Yes, and because of nowadays we have really less patients because we defer some of the procedures, so we don't have this problem. But yes, of course, if it's emergent, we should take immediately. But we don't have this problem frequently because overall we have less patients nowadays.
So one question from Dr. Inanç is asking about the STEMI patients who have mild hypervolemia and risk of intubation. So would you prefer to intubate them electively prior to their arrival to cath lab, or do you wait until?
We prefer elective intubation, and it is advised.
Another comment from Dr. Soydan is he says that they have been encountering some barriers with the infection diseases consultations. So they say that they are doing the diagnostic test without consulting to the infectious diseases department, but they suspect and they ask for the performance of the swab test, I guess, prior to the intervention, if I understood correctly. Okay. So another question.
Yes, Duygu.
So another question is about the anticoagulant therapy again. They ask if you would like to use oral anticoagulant therapy as opposed to clopidogrel in COVID-19 patients due to their procoagulant status.
I personally prefer the ticagrelor because it has less cytochrome interaction. So we mostly prefer the ticagrelor instead of clopidogrel.
So one question from Dr. Karakush is about the access approaches in angiography. He's asking if transfemoral approaches should preferred more commonly than transradial approach in patients with COVID-19.
Yeah, it will be easy to protect yourself. But for our elective patients, yes, we differ some, but for our elective patients, we are still doing transradial way, but I think the transfemoral will be better.
And I also wonder if you have seen an increase in type 2 MI patients in your clinical practice, or myocardial infarction with normal coronary arteries.
Yeah, in our center, we didn't have much COVID patients, so I didn't encounter.
Okay, so I think we are approaching to the end of our session tonight. So I'd like to thank you, Dr. Okutucu and Dr. Hatem once more. And at last but not the least, I would like to thank our audience for their interactive participation. I hope you all enjoyed today's session, and I would like to remind you that next week, Dr. Okutucu will be moderating, and here you see Dr. De Campo Martin from Brazil will be our guest. Hope to see you all next week on May 12th. So good night.